question is from Ashish Singh. Please. Yes.
Thank you, ma'am. First of all, good afternoon, everyone. And I would like to thank Dr. Sandeep and the whole Wishwa team for organizing this wonderful talk. And you have explained it very wonderfully. I would like to give a brief introduction about myself. Am I audible?
Yes, sir. Yes, sir.
So I'm Ashish Singh from Haryana. I'm a Ph.D. Neuroscience student at National Brain Research Center, Manesar, Haryana, specifically working on the non-substance addiction. And I was really engaged in your discussion. It was really explained very well. So I have a series of questions. So I should go sequentially, I think.
Yeah.
So first thing, as you explained it wonderfully, the treatment, explained the addiction. I would like to ask you some treatments which are available for addicts.
Sure, sir. So the first thing is, as I said, a person who is in addiction, they have severe withdrawal symptoms. The first part in your treatment is supporting him. Don't label him. Treat him as a normal patient. Then he will open up and tell everything. And next is the treating the withdrawal symptoms. The withdrawal symptoms is that the receptors are becoming hyperactive. So you need to give medications to settle down the receptors. So there are advanced medications. For each and every drug profile, there is a detox medication. We call it detox. So the first once patient gets admitted or on the OP basis, we do the detox treatment. Once the detox treatment is done, he will accept treatment. Most of the patients, they love to quit the substance, but they don't know how to quit, and they have the fear of quitting because of the withdrawal symptoms. So if you are successful in treating withdrawal symptoms, you have done 80%. Next 20% is relapse prevention. So next relapse prevention is 20%. What you do is, there are advanced drugs now. For example, naltrexone is for alcohol, acamprosate is for alcohol, disulfiram is for alcohol. For smoking, there is varenicline. There are different drugs for different profile of substances. You start the relapse prevention drugs, which will reduce the risk of relapse in the patient. So, and also we have advanced neuromodulation techniques for example, in NIMHANS, AIMS, Delhi, and in Asha Hospital, Banjara Hills, we have a separate mission called transmagnetic stimulation, which is the advanced technique, non-invasive, no side effects. Each session is 20 minutes. And this, once you give this transmagnetic stimulation, we select the brain part which is hyperactive or which is hypoactive. And if it is hypoactive, we increase the activity. If it is hyperactive, we decrease the activity. So there are now FDA approved protocols for depression, OCD, and smoking. And in the near future, the protocols will come for everything. We have CE protocols, European protocols for alcohol also. We are practicing on daily basis. This transmagnetic stimulation, the magnetic wave goes into the brain and will act on the part for craving, the insula, the midbrain. So this is the neuromodulation medication. And the next important part is counseling. Counseling both the patient and the family. And the most important part after discharge is follow-up. The patients who are coming for follow-up are in contact with the doctor, following a routine, not skipping the medication. They have a good family support. They have a job for their food, water, shelter, or some routine or motivating thing. Usually there is a less chance of relapse. So even after discharge, the biggest part is following the patient, following the client. You need to make a call. They will not come. As a doctor, I make call, I message them. There is a feedback call we do, and we'll ask the patient to come back. And that is the routine thing we do.
Okay, that's really nice explanation, sir. And I'm really glad.
Yes.
But I have another question on the particular answer. Like, as you mentioned about the few medications, and it is a kind of perception in my mind, or kind of perception in society as well. These medication itself target these dopamine receptors in our brain. So somehow they also supply these dopamine neurotransmitters in our brain.
Yes, sir. See, that's what I'm saying. Even though it's supplying the dopamine, for example, for diabetes, you give insulin. because the insulin is low in your blood and you're supplying insulin. Now in addiction, something is happening. Either I have to decrease it or increase it. There is no harm. For example, nicotine replacement therapy has been highly successful for smokers. You're supplying the same nicotine, but you're reducing 7,000 chemicals in a cigarette. Each cigarette smoke has 7,000 chemicals, and the wonderful chemical which is helpful is only nicotine. All other chemicals are carcinogenic. So by supplying the nicotine, you're giving the nicotine to your brain, but you're making him addicted to nicotine. But you're reducing the 6,999 carcinogenic chemicals in your brain, which kills you. So harm reduction is the baseline or the bottom line for pharmacotherapy. It is you reduce the harm in them first. Bring them back to the society, help them. Yeah.
Thank you. As ma'am asked about legalized drugs in the conversation to you, I would also bring the point of that mobiles as the most legalized drug.
Most legalized. So 24/7 dopamine is your iPhone.
Yes. So I would like you to bring some more insights upon this non-substance addiction perspective. Like I'm specifically working in that, so I would like you to
non-substance addiction, right?
Like mobile and all those behavioral addiction.
See, the behavioral addiction, gambling, porn, internet, gaming, all these things also act on the same reward pathway, the mesolimbic pathway, and increase the dopamine. So there is nothing different. This is increasing dopamine, that is increasing the dopamine, but the level of dopamine, how it is increasing, when it is increasing, it is different. Now we are trying to find out substrates and receptors for gambling. In the near future, we'll get a very good medication for gambling. Now the current medication also is, we are trying naltrexone and fluoxetine, because gambling is considered as an compulsive disorder. I have that compulsion to gamble. So we are giving drugs to control this impulsivity and compulsivity in gambling. The fluoxetine will reduce this impulsivity and compulsivity. And we are having good success rates, both in pharmacotherapy and also psychological therapies for gambling.
Okay.
Yeah.
Sir, as you told, you are a counselor as well. So do you have the patients of mobile addictions and all those things? Do you
See, after COVID, all the patients from addictions, children, when the transfer of books to iPad, there is a lot of gaming addictions and internet addictions we see on daily basis. So we see, the main thing is without technology, we can't live.
Yep.
Okay, I can't live. Without this laptop, I can't conduct this Zoom meeting. Without the phone, I can't contact WishwaTalks. Anything is not possible, practically not possible. But how much we use, how much it is helping us, how much we are taking it, and how much we have to measure it. In the same way, whether we are increasing the behavior time, whether when we are reducing the behavior, we are having discomfort, whether making the behavior or the gambling or gaming as a priority, whether I'm losing the control of gambling or gaming, or whether irrespective of harm, though it is causing me some harm, I'm using it. We need to see the checklist of addictions for behavioral disorders. And there is there's a concept called dopamine detox. So we are addicted to dopamine, right? Now the theory now in the Western world and even in India, now it's being practiced. Dopamine detox is nothing but you list out the 10 pleasurable things in your life now. Okay? Your iPhone, your KFC, your AC, your comforts, everything. You list out the top 10 things in your life and stop all these top 10 things for 2 days in a week. Saturday and Sunday, don't use phone and laptops, car, nothing. You should go walking. You should not eat KFC. You should eat the natural organic things. So you are giving the brain some time to regenerate. Don't blindly dependent on dopamine. I will detox the dopamine. I'll reduce dopamine for 2 days a week. And if you practice this, your brain will be healthy.
Yes, sir. So the other thing is that, as you mentioned about the psychological characterization of addiction, like we categorize people who are addicted or who are not. You are just using things based on psychological tests. So it's something like criterias, and we are feeling them. Is there any concrete method of identifying who are addicted and who are not addicted? Who are just
that's what I'm saying. No, it's not about only the criteria. the physical symptoms you have with withdrawals, like the withdrawal symptoms are very horrible. If you are having withdrawal symptoms, you're definitely addicted to the substance. And second thing, if it's just an habit, it will not cause family problems, it will not cause financial problems, it will not cause personal problems, it will not cause occupational problems, it will not cause your behavioral problems, it will not cause aggression, it will not cause anything. But addiction, you can definitely, by the time the client comes, he comes with all these problems. So there's definitely a big demarcation between habit and addiction. It's not, and as you said, if at all you want some legalized test for addiction, you can go for a PET scan or fMRI, which is too costly. But as technology develops, even the scan prices will come down. We'll definitely have a PET scan and fMRI. If you see in the addicted brain, fMRI shows hyperactivity of the central lobe.
Yes, sir.
Because it is the dopamine lobe. And it shows decreased activity in frontal lobe, because you lose the judgment and decision-making capacity in addictions.
We are also using this PET and fMRI for scanning those addicts. But
and now currently in India, we are using it for research, but definitely as future, there should be some proven evidence. The evidence that it comes, I think it will come into the market for clinical use also.
Recruitment of the patient subjects, because at recruitment stage, we can't use them. We can use the identified patients only. So that's why I asked the question. Is there any so we can recruit better? Also, sir, I would like to just mention at the end that we are like from the behalf of NBRC, National Brain Research Center, as we are working on non-substance addiction. So we would like to collaborate with the people professionals working in this field. So
definitely.
I will mail you as well.
I my number, my personal number, and also the number for the clinical, the hospital appointment numbers, I think I gave Trishant to distribute it in the chat box.
It's been shared in the chat, sir.
Yeah.
Thank you so much, sir. It's really humble response from your side. That's so nice.
Thank you, Ashish. That was a long questions, but some of them are very pertinent. So, yes. Our next question